Hello, my name is Dr. Richard Thwaites, and I'm the Medical Director of Falcon Physician Reviews. And this is the introduction to the anatomy section for Level 1 of the COMLEX and Step 1 of the USMLE. Your instructor, Dr. Craig Goodmurphy, has been assisting medical students both in the MD and the osteopathic community for many years preparing for these exams. Anatomy, the foundation of medical science, is one of the most important things you can study when you're preparing for these exams. So without further hesitation, let us begin the anatomy modules.
Welcome to Falcon Reviews. My name is Dr. Craig Goodmurphy. I'm Associate Professor and Director of Anatomy and Embryology at Eastern Virginia Medical School in the Departments of Pathology and Anatomy. Anatomy will be a golden thread woven through many of the subjects to follow. We clearly can't do everything, but we will concentrate on reminding you of some of the clinical anatomy relevant to Step 1, and even a bit of basic anatomy that will help you to appreciate that golden thread as you continue your preparation for board exams. So get ready to engage your brain as we start with Module 1 and discuss timelines and teratogens and some of the basic types of developmental defects that you'll see along the way. Let's start by focusing in using a question. The average gestational period in humans is how many days from the first day of the last menstruation? Concentrate and think about your answer, and then we'll move on. 280 days is the response that we're looking for. Let's look at the timeline in general on this next slide and start to get an understanding of where some of these came from. Through this course, we'll be looking at prenatal to postnatal periods in many different ways. This will go from conception to death, and with this really important event in the middle called birth. Around either side of this, within a couple months, is called the perinatal period. Up to 1 year is known as the infancy period, and then up to the 4th week after birth is the neonatal period. Childhood will typically go from 1 through 12, 13, with a little bit of variation depending on male-female status. Adolescence typically goes from 13 to 17. And puberty will strike somewhere in between that age group, where there will be secondary sex characteristics developing as a result of hormonal influences in both male and female. Adulthood, typically from 18 through 21 to 25, again dependent on gender. And then by the end of that period, growth stages are complete. Finally, you'll get into middle age and old age, of which I've not put dates, but typically I like to think that middle age is 1 year older than me. If we go back into the prenatal periods, we'll be talking about the idea of conceptus, which typically is what the entire component of the implanted and fertilized embryo will be called up through that 1st and 2nd week until it implants into the uterus. Then we'll have the embryonic period, which includes this component after the point of fertilization, but there is a critical period of 3 to 8 weeks. And then finally, the fetal period will be 9 through 38 weeks. Let's break this down a little bit further. For clinical purposes, oftentimes because there's no indication of when fertilization actually occurs, they go from the last menstrual period, which is 1 to 2 weeks prior to, typically 14 days prior to fertilization. So the embryonic age is typically counted from the time of fertilization, which makes 266 days or 38 weeks, which can be divided into 3 equal trimesters of roughly 12.6 weeks each. The gestational age, as we discussed in the question prior, includes the date of last menstrual period because it was mentioned in the question. Therefore, from last menstrual period, adding 14 days to this 266 embryonic period, we have 40 weeks, which is 9 calendar months. It's important to have these timelines clear in your mind, both for the questions that will be asked in Step 1 and so that there's no confusion amongst even your colleagues and your patients that you'll see later on. Looking at the embryologic timeline, the gestational period here can be divided into two phases. The embryonic period, which is up to 8 weeks, and then that fetal period from 9th week to birth. We're going to focus in on some of the critical periods because these are important for teratogen influences, and the mother needs to be guarded from chemical injuries or environmental and other injuries will take place and affect the fetus. This is just a chart to show you a quick breakdown of some of the sensitivities of each system of the body as it forms when it's most susceptible to teratogen influence. I suggest you spend a little bit of time, but as you can see, most of the heavy teratogen involvements is in that critical period from 3 to 8 weeks, with only a few systems such as the central nervous system, the ears, which would develop late, and also the genitalia, which will develop quite late as well. Here's a list of some common teratogens. I think it's worth looking at some of these in a quick overview to make sure that you have an idea of what systems they're affected by. For instance, as an example, the cytomegalovirus is going to have cerebral calcification and microcephaly, potentially hydrocephalus, and typically mental retardation as some of the common side effects of being infected by the cytomegalovirus. Alcohol, another important one in our social culture, will have fetal alcohol syndrome, which is a entire repertoire of effects. It will stunt intrauterine growth, typically will lead to microcephaly and mental retardation, and is characterized by a short palpebral fissure. Retinoic acid will oftentimes be involved in neural tube and facial defects if they're low in retinoic acid. And then tetracycline will oftentimes stain teeth and cause hypoplasia of the enamel development. As you go through the courses, and you'll talk in even other courses that you'll be doing your preparation, you'll talk about other embryonic defects that we don't discuss or don't have time to discuss, all in anatomy. Try to categorize them into some of these 6 major components. For instance, we'll go through a couple examples of genetic, chemical, nutritional, gestational, molecular, and signaling gradient problems, and even infectious agents, as we've discussed in the previous slide. Starting with genetic or non-disjunction issues, you have Klinefelter syndrome, which is going to be an XXY genotype, which typically is going to have a sterile male with hyalinization of the testicles, and therefore they're tending to be underdeveloped and small. They'll have elongated limbs and have a lower intelligence and oftentimes have gynecomastia. Looking at a female genetic disorder, Turner syndrome is a common one that's tested on the USMLE. There's often a short stature and a webbing of the neck, a very broad chest plate, and widely separated nipples as a result of that, lymphedema of the feet and hands, and then a lack of sexual maturity. Down syndrome, another commonly tested item, will be a flat nasal bridge, slanting palpebral fissures, oftentimes associated with an over 40 mother, and they'll have a low alpha-fetoprotein content that will be a key component and a red flag in any of your items. Mental deficiencies and atrial septal defects, as well as some GI defects, are oftentimes associated with Down syndrome. Looking at some examples in the chemical and drug regions, you can have the typical thalidomide, which is now back in the market, even in America. This was typically used several decades ago for morning sickness in mothers in Europe, oftentimes associated with amelia, or absence of the limbs, phocomelia, short limbs, and hypoplasticity of the bones. In association with this, there was absence of certain bones, the external ear was oftentimes abnormal, and then facial palsies and eye abnormalities were often in association with this as well. Heart defects and GI tract, urinary, and genital malformations were not uncommon either. The standard feature, though, for thalidomide poisoning during pregnancy is the amelia or phocomelia, and oftentimes which one occurs, whether it was a short limb or absence of a limb, depended on when the mother was taking the thalidomide. Remember, the earlier it is, the more likely the limb is to be entirely truncated. The later it is in the critical period for limb development, towards week 5, the more likely it was to be a short limb. And a couple chemical things that are common in today's world is warfarin poisoning, which will give small noses, hydrocephalus, retardation, and clefting of the palate, and also fetal alcohol syndrome, one of the very common forms of chemical alteration in the embryo, with fetal alcohol syndromes having an entire range, microcephalus, flat philtrum, and reduced intelligence that we mentioned earlier and showed up in that previous chart. Folic acid deficiency is now a hot topic for testing because they're making social efforts to ensure that women of all childbearing age and sexual activity should have a folic acid supplement, and this is believed that it will reduce neural tube defects by up to 60 to 80%. Looking at gestational issues, these will be effects from the microenvironment within the embryonic placental sac, and the amniotic banding that can occur from that can oftentimes cause anything from simple removal of toes by banding around a developing digit and either allowing it to be stunted or actually severing it, all the way to the bottom picture, which shows amniotic banding that got across the fetus's head and caused death. Radiation effects are going to be important, and this is a topic which will oftentimes be associated with imaging, and it often has malformations, retardation, and a high incidence of childhood cancers. Signaling issues, there's a few key ones that you'll want to be aware of for limb formation, with the apical ectodermal ridge being an important red flag feature for the development of the limb bud, as well as retinoic acid, which can oftentimes cause mirroring of limb buds, or things as simple as developmental adrenal hypoplasia and the lack of 21-hydroxylase deficiency. This will lead to the genitalia being nondescript. Here we have some words that will talk a little bit about some of the things that we just looked at in pictures. I think it's a good thing for you to go back through some of these and make sure that you understand both the visual appearance of these as well as some of the major systems that are affected. And now for nutritional. We talked already about folic acid, and then gestational with banding. Maternal diabetes we'll come back to, but remember that's an important one for macrosomia, which will cause very large babies because of the neonatal hypoglycemia. It can go all the way to stillborn or just very large. Maternal smoking will cause a reduction in infant size, and oftentimes can lead to having a stillborn infant because of the carcinogens, including arsenic and cyanide, which are considered present in smoke. We've already discussed signaling gradients. These will have effects in several systems, one of which is the renal agenesis, which can cause a result of the ureteric bud not to meet the metanephros. We'll discuss this a little bit later on. Some of the red flags in the testing items will include oligohydramnios and unilateral renal agenesis. Oftentimes you should suspect those kind of issues when you have a single umbilical artery as well. Polydactyly we discussed, congenital adrenal hyperplasia we discussed, and we've also looked at a few of the infectious agents. Now, let's move on to gametogenesis. If you'll remember from a couple years ago when we first started talking about this stuff at your respective medical schools, that gamete is the recombination of the male sperm and the female ovum to reproduce the diploid chromosomal number. When the two fuse together, they become a zygote, and that happens at the time of fertilization. The males and females will look and have very different strategies to gamete production. And though we're not going to spend a significant amount of time going through all the various components of that, as I think it's at this point fairly low yield, the results of that are oftentimes important, since it's at these points during the development of the gametes that you'll get non-disjunction genetic malformations, which has a significant effect on the viability of pregnancies. The female strategy to gametogenesis is to develop one very high-quality oocyte. It will be an incredibly large cell, one of the largest in the human body, and it will maintain a lot of its cytoplasm and discard small polar bodies which have the entire genetic complement but do not have the cytoplasm. Whereas male strategies will be to produce millions of gametes, from anywhere from 3 to 600 million per ejaculate, and try to use this huge number of gametes in order to reach the site of fertilization. Let's move to another question. A young couple are trying to conceive and begin their family. After 2 years of trying, they've come to a fertility clinic to seek some answers. You determine that the husband has a low sperm count. What is the sperm count per ejaculate below which a male is generally considered to be sterile? If you wish, pause the tape and you can consider your answer before we move on. We're looking for 50 million in an ejaculate. If only 50 million sperm are present in an ejaculate, there'll be too small of a number of sperm to actually reach the oocyte, since only 1%, much less than 1%, will actually make it to the egg itself, and we'll talk about this a little bit further. When we think about gamete stimulation and fertility problems, think about female infertility, which has many causes, not all of which we'll have time to discuss right now, but one of the major components is the problems with ovulation, and they'll oftentimes prescribe some of the fertility medicines, such as clomiphene citrate, to help with treatments of ovulation difficulty. This will stimulate FSH and LH, and that will have many follicles and increase the incidence of multiple pregnancies. Oftentimes, there's fertilization blockage that is a major component, and this can come from either blocked uterine tubes, scars from previous infections, or problems in the uterus itself. Or there can be hormonal problems that affect menstrual cycle and implantation phases by having either low levels of progesterone or the corpus luteum is not robust enough to maintain the pregnancy by stimulating the production and the presentation of the endometrium. As far as male infertility, it also has many reasons. One of the major ones, as we discussed in the question, is that low sperm count. If the sperm shape has a difficulty or is malformed, or there's no motility to it, this will also create the incidence of infertility in males. There can be physical factors such as scrotal varices, where the venous dilations around the vas deferens will create too much heat for proper spermiogenesis in the testicle. There can be infection as well as disease that can affect the male fertility cycle. Low testosterone levels and even obesity. Let's break into the 4 phases of the menstrual cycle. The menstrual cycle will start with the menstrual or the flow phase, which is the 4 or 5 days of discharge that occur from the vaginal canal, and when the uterus sloughs off through the hydrodissection that occurs when the spiral arteries start to break away. The proliferative phase will follow this, and it's an estrogenic phase, or sometimes known as the follicular phase. Typically will last 9 days or so, and the proliferation of the endometrium is a key feature of this phase of menstrual cycle. This is the area where the endometrium is repaired after the menstrual phase, and the estrogen from the ovarian follicle will start to begin the development of the oocyte and the Graafian follicle. When it gets to the secretory phase, this is the progesterone heavy phase, also known as progravid phase, and this is typically 13 or 14 days, and it's under the influence of progesterone from the corpus luteum, and then the estrogen as well from the thecal cells. This will develop further growth of the endometrium and prepare it for potential implantation. Then the fourth, premenstrual phase, or ischemic phase, if there is no fertilization, the spiral arteries of the developed endometrium will start to regress and break down, which will allow blood to flow between the layers of the functional and basal layers, and this will hydrodissect away the endometrial lining that's been prepared for implantation, which has never occurred, and then we'll be back into the menstrual cycle with the menstrual phase. So this occurs because of a reduction in the progesterone levels of the blood, which should be maintained if fertilization occurs by some crosstalk that occurs between the zygote and the corpus luteum. Then glandular secretions will cease, spasms of the spiral arteries, and sloughing. Let's look at it in graphic form. Starting with the hypothalamus, there'll be gonadotropic releasing hormones, which will affect the pituitary and start to release gonadotropic hormones into the vascular stream, which include follicle stimulating hormone and luteinizing hormone. These two hormones will start to drive the development of the primordial oocytes into a mature Graafian follicle. There'll be a development of typically 12 to 15 primordial follicles, but one of them will develop faster than the others and become more sensitive to the hormones that are being released into the vascular stream. And this will then allow their thecal cells to produce the hormones that will shut down the competing oocytes' development so that they can use one mature Graafian follicle to be stimulated and released each month. After that's released, it becomes the corpus luteum, and that will start to release progesterone and estrogen as the released oocyte travels down the fallopian tube, and the endometrial lining will be prepared for implantation should fertilization occur. And this graphic here shows the relative thickness of the endometrial lining as it goes through the various phases that we've discussed already. And this will include the menstrual from day 1 to 5, the proliferative, the secretory, the ischemic phases, and then back into a menstrual phase. It's typically the post-ovulatory period that is constant at 14 days, and the proliferative that will vary between menstrual cycle to have it between 23 days and even 35 days. In the next section, we'll look at fertilization through implantation.